Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight, and on behalf of everyone at Eversight, I would like to thank you for joining tonight's program, Identification and Management of Limbal Stem Cells Deficiency. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the webinar. At this time, I would like to introduce our speaker for this evening, Dr. Jeffrey Goshe. Dr. Goshe joined Cleveland Clinic Cole Eye Institute after completing a fellowship in cornea and external disease at the Devers Eye Institute in Portland, Oregon. During his fellowship, Dr. Goshe trained with Mark Terry, a world-renowned leader in cornea transplantation. Dr. Goshe is actively researching corneal transplantation techniques and has published peer-reviewed journal articles on DMEC, DSEC, and DOC. He completed his ophthalmology residency at Cole Eye Institute, where he was elected chief resident, served on the resident education committee, and won the Best Resident Paper Presentation Award at the 2009 Cole Eye Institute Annual Research and Alumni Meeting. Dr. Goshe graduated from Case Western Reserve University School of Medicine, where he was inducted into Alpha Omega Alpha. Dr. Goshe served as Assistant Residency Program Director from 2011 to 2014 and was named the Residency Program Director in 2014. He also has served as a content expert in cornea and external disease for the American Academy of Ophthalmology Self-Assessment Commitment since 2013. Dr. Goshe is also a member of the Alpha Omega Alpha Honor Medical Society. Dr. Goshe, you're welcome to begin.
Thank you very much. And that did remind me, it sounds like it's time for me to update my bio on the Cleveland Clinic website. I appreciate everyone coming here. I'm guessing they're probably not here about my 2009 Best Resident presentation at the Cleveland Clinic Research Day. So I thank you for mentioning it, but I probably need to put some updated references in there. So the presentation tonight, and forgive me, I'm nursing a little bit of a hoarse voice here. So I'm going back and forth to the T. But basically the presentation tonight is going to be covering some basics and some more, let's say, specific or advanced examples of identification and management of limbal stem cell deficiency. And the goal here is to provide a wide range of information about this that will appeal to people at different levels. I know there's going to be people, everything between ancillary personnel, optometrists, comprehensive people, as well as cornea specialists. So I tried to give a little bit of something for everyone here. So apologies if things are either below or above your level at certain points, but I wanted to give kind of a broad view here. Financial disclosure, I have given speaking, received speaking fees from DownPay. So first things first, what does this have to do with the talk? So the point of this is I want to give some context for my role here. And, when it comes to something that's as complicated and nuanced and multidisciplinary as limbal stem cell deficiency, especially when you get to the upper levels of transplantation with all the immunosuppression, you need there's a handful of people, the people that are the admirals of the fleet. And I will say, I will openly confess that I don't consider myself one of those people. So I, obviously just gave you, imagine whoever it is you want to be here, of the people you've heard of. I would say I consider myself more one of these people up here when it comes to it. I'm one of the labormen, ensign third class, or whatever you want to call it. I picked the shortest one to put the arrow next to. For those of you that know me, I'm not super tall. But the point of this is that everyone can't steer the ship. So we're not all admirals here. Some of us are just scrubbing the poop deck. So I consider myself an expert poop deck scrubber, but what I mean is that I'm going to give you sort of my approach as a person who is a practical ophthalmologist and cornea specialist, but not one of those elite few in the world that might say, okay, this is how you do the brand most newest limbal stem cell graft with the newest immunosuppression, and that is not me. There will hopefully be some useful things for everyone here. So we'll do a little bit of background, talk about the identification of the disease, some of the risk factors, the treatment options, and then kind of delve into some case examples with the hope being that those give a little bit more color to the discussion and also are opportunities for people to weigh in. And I am certain that with the expertise of the group that is on the line today, there are going to be people that have very, very excellent suggestions and recommendations about things that they would do differently in some of these cases. So for those of you that are unaware, obviously the epithelial stem cells are these mysterious population of cells that reside in or around the palisades of Vogt, which are these little, sometimes extremely visible little striations that you can see, undulations in the peripheral limbus. And from there, these stem cells provide the dividing, amplifying cells, which then undergo, 20 to 30 replications and serve to repopulate the corneal epithelium about once every week. So, in many cases, limbal stem cells wear out or fail due to a variety of reasons: age, genetic factors such as aniridia, inflammation, such as things like Stevens-Johnson syndrome, which can be extremely devastating, trauma, anything that's going to involve toxic injuries, thermal, alkali, the things that obviously we fear the most when it comes to the traumatic injuries to the ocular surface. So that pathophysiology involves essentially the limbal stem cell function to prevent the advancement of those conjunctival epithelial cells into the cornea. And the true pathologic definition of that limbal stem cell deficiency is when those cells can no longer inhibit, and therefore the conjunctival epithelial cells begin to migrate into the cornea. And those epithelial and goblet cells can be found within or interspersed, or in some cases even replacing entirely the corneal epithelial layer, which provides its characteristic clinical appearance. So first things first, if you are going to be assessing the limbal stem cell health and you are looking for a very basic strategy, the key is instill the fluorescein, and you have to wait. You have to give it more than a second or two to allow some of that late staining to take place, and also to allow, if you instill fluorescein, some of the excess to wash away. I prefer the individual fluorescein strips as opposed to the solution because it otherwise saturates the entire tear film for too long. So here, a kind of a typical example of a patient with limbal stem cell dysfunction or sort of partial deficiency due to contact lens overwear. And you can see on the color image here, that characteristic vascular pannus growing in over the top, and maybe less visible here on this magnification, but there is a cascading pattern arising from the superior limbus here that basically creates an almost visible ridge, which you can see as this little gray line, from where those dysfunctional cells are then running into some of the less dysfunctional cells coming in from below. So that is a kind of a characteristic appearance of some of these contact lens wearers in the early to moderate stage. So I would specify to say that the early features of limbal stem cell symptoms are for the most part relatively non-specific. Many of these patients, if not the vast majority, are completely asymptomatic until they develop deficiency to the point where the central visual axis is directly compromised. If they're contact lens wearers, even then, the contacts often mask that. Blurry vision, of course, is sort of the byproduct of that. Some, although I'd say not the majority, will complain of more ocular surface type discomfort, so dry eye-like symptoms, although again, contact lenses can be deceiving. And many times the history will they will come in under the assumption that their soft contact lenses are making them better if these are soft contact lens induced limbal stem cell deficiency patients because of that masking effect. So the signs are going to be the things you're more familiar with, assessing with the fluorescein pattern, such as that diffuse, which is often sectoral initially, perilimbal or cascading appearance, which often has a whirling or kind of a dysfunctional wandering appearance of the epithelium. You can sometimes see demarcation ridges or even islands of necrotic cells, depending on where they get isolated, and then the progressive conjunctivalization or pannus of the periphery in more advanced cases. So I'm going to go through a couple of examples here. 47-year-old contact lens wearer with a 20-year history. Again, looking at the superior limbus, which in contact lens wearers for a variety of proposed mechanisms, either due to hypoxic stress or mechanical stress. The superior limbus tends to be the most affected in those patients, seeing the encroachment of vessels. And then here with the staining pattern, you can see this sort of, again, cascading or a little bit of a stellate pattern coming from above and it tracks and sort of loses momentum the further it gets away from the limbus. And again, you're seeing the mixture of dysfunctional epithelial cells, often interspersed with some of the conjunctival epithelial cells, creating some of these atypical patterns. The patterns can be incredibly striking. I've seen remarkably artistic and unusual looking patterns due to limbal stem cell deficiency here. When I first saw this one, I was trying to remember what it reminded me of. And then I could think of it. I said, you know what, that looks exactly like one of those chameleon pictures there. If you're an 80s fan, that may remind you of their chameleon-related trivia as well. Here is an example of a patient with a hybrid lens. Hybrid lenses, you know, a lot of our optometrists that fit complex corneas will like these lenses because they can get the hard lens benefit with the soft lens feel. But they are, in my opinion, at least very dangerous if they're misfit, because just like the soft lenses, they put a lot of stress to the limbus. Here you can see inferiorly kind of that flame-shaped or sort of whirling appearance here, as well as some diffuse perilimbal dysfunction or staining around the edges. So these are important to recognize before they become too advanced. Here is a different example, just showing you sort of the breadth of different causes, as well as how they have a very overlapping presentation. This is a patient with early OCP, and you can see here sort of those epithelial ridges that are being created here on the fluorescein, showing a little bit of a pooling and some late staining corresponding to the edge of where that dysfunctional epithelium is running into some of the more healthy epithelium. The late features are obviously the ones we're trying to avoid. And if I could give my own takeaway with anything limbal stem cell related is get it as early as you possibly can and get it under control, because I'm always distraught for the patients that arrive after a 5-year history, you know, particularly those that have preventable causes like contact lens overwear, and you look and you see what's obviously a very, very chronic looking appearance, and they may already be on the point of no return in terms of going on to limbal stem cell failure, which can be a disastrously more complicated problem to manage. Photophobia, typically as they become more and more atypical with their cells, it becomes worse. And pain is variable. I'd say there's a relatively high concordance in a lot of these patients with neurotrophic causes. So some of these patients will be entirely painless despite having relatively significant epithelial changes. The signs as you get more advanced, instead of more sectoral, you end up with usually more diffuse changes, even up to 360, and you lose even a regular, even any semblance of regular epithelial patterns. These patients often, as they get into the more advanced stages, present with recurring epithelial defects, which can be sometimes mistaken as erosions or other causes. And then to the worst of the worst, the more conjunctivalized or keratinized vascular surface, or the combined with subepithelial scarring and haze, and these are often severely debilitated patients at this point. This is a patient with a combination of soft contact lens wear as well as diabetic neuropathy, and this is again one of these situations where this patient had been wearing soft contact lenses for about 5 years, but certainly, you know, at this stage you can see the subepithelial haze and scarring has already started to become relatively diffuse as the entire superior 180 degrees of cornea epithelium. These are the cases where you get into significantly worse choices when it comes to outcomes. Similarly, along that same vein, this is a patient with idiopathic limbal stem cell dysfunction. She had an extremely brief course of contact lens wear in her early 60s, less than a month. But this is largely believed to be related to either to chronic lid margin disease, just idiopathic causes, which for whatever reason tend to affect females more commonly than males and obviously progress with age. But you can see on her right eye already diffuse vascularization of the corneal surface, and the left eye, which is already starting to show signs of some peripheral neovascularization, which began to progress further as well. So not all cases have a real obvious identifiable cause, but the end result is usually the same. Here is a patient showing a young lady that had Stevens-Johnson syndrome from, I believe it was aspirin or doxycycline at the age of 1. And the image is a little bit overexposed there, but basically a diffusely conjunctivalized surface with neovascularization. Most impressively though, that patient actually is still under my care now at the age of 17 or 18 and doing very well with contact lenses, scleral lenses. Here is, again, a more advanced stage. This is a 61-year-old with later stage OCP. You can see the symblephera impeding the lid opening, a scarred and vascularized conjunctival surface with diffuse entropion and trichiasis. So these are the, again, getting to the worst of the worst. So if you're looking at these from a medical treatment perspective, which ideally is the time to catch these patients before they really get to the more surgically complicated options, you know, first things first is to identify and remove any of these offending stimuli. And I'd say of these patients, you know, 90% that I see, you know, that are preventable for progression are due to soft contact lens wear and often soft contact lens abuse. So these patients are usually extremely attached both physically and emotionally to their contact lenses. So getting them out of their lenses takes often more than a few minute discussion. And I know some of them often disappear and then come back later, having disregarded that advice and sought contact lenses elsewhere and continued to wear them until they've gotten worse and worse. And I've seen obviously even young patients in their early 20s come in with just absolutely horrific consequences of that type of lens wear. Toxic medications, I'd say, is more the older age group or the chronic age group. These are the patients I think of that are often on multiple long-term drops, often glaucoma patients that have been subject to years and years or decades worth of drops, including multiple classes of medications, which can be individually in some cases toxic, or cumulative effect of multiple preserved drops and numerous doses of BAK given over decades of time, often coupled with even procedures that use things like antimetabolites like mitomycin or 5-FU. So these are cases, again, you want to try to look for these early, and if you're involved in the patients that have glaucoma, you know, you want to minimize and watch closely for signs of toxicity. Inflammatory issues are always critical to address. You know, the things that I see, you know, a lot of lid margin disease. So sometimes the use of weak or chronic steroids or non-steroidal alternative, not NSAIDs, but alternative agents, things like cyclosporin, would be considerations for these patients. I don't think that steroids themselves are the mainstay of these conditions in most patients, but any type of inflammatory tear film type of issue is going to certainly not contribute to the health of those stem cells. You certainly want to address dry eye. Dry eye is if not universally concordant with it, it is part of the treatment regimen for almost any type of limbal stem cell deficiency issue due to the nurturing effect of moisture on the epithelium. So even if they don't have sort of true aqueous deficiency per se, or dry eye that you would define otherwise, these patients typically are going to benefit from anything that can increase the moisture of their surface. So obviously working through your progressions of tears and plugs, and then your commercial dry eye drops. And I do find in some of these patients a therapeutic benefit of some of the protein or human-derived solutions such as plasma or serum tears. So those are stepwise. I usually work my way across. But in some cases, these are still completely ineffective when you get to the more later stages. And then, as I mentioned before, lid margin disease, and I should also mention on there, this will come up in the surgical side, you know, lid margin is also related to exposure. A lot of these patients have concordant issues with the health of the lids as well as the function of their lids. And then, quite honestly, if you've done all of the medical options and the patient has a relatively preserved fornix, and would be able to handle a contact lens, I am a huge fan and believer in getting these patients into scleral lenses, which I think offer both a therapeutic as well as a visual benefit for the patients in terms of both providing let's say, a relatively protected environment for the stem cells, as well as the ability to provide vision consistent with a hard contact lens. And this is ideally where patients get to if they can no longer get better vision with anything else before we get to the more complicated surgical options. This just to give you an example of sort of the time course as well as the difference on these patients. This is a 30-some-year-old female that had been wearing contacts for a decade or so. You can see that diffuse, irregular. I think of the individual punctate epithelial staining pattern as more like the little wandering sequence. I think those For those of you that are 38 or older that used to see the family circus cartoons where they show the cartoon of the kids walking all around the house or the neighborhood and then kind of showing the time lapse of what they did all day, essentially a little trail that kind of shows you where they've been. That's what these stem cells, to me, always look like. And even if they're not to the later stages, I consider that a dysfunctional or sort of a pre-overt limbal stem cell sort of deficiency pattern that I think needs to be addressed. And then just within 8 weeks, she gets back to 20/25 and essentially 95% resolution of that staining pattern. So it's a very powerful treatment to get these patients out of their contact. And you have to hold their hand, because for the first 2, 3, 4 weeks, they will call you every day and say their eyes feel worse and they see worse until they finally get over that threshold. There are things that can mimic other conditions that can be attributable to limbal stem cells. This was a patient that was referred in to me, a hard lens wearer actually, although a larger diameter hard lens for a possible CIN, and had this kind of very unusual looking stellate pattern there, but it didn't have the staining pattern. This is all sort of negative staining, which I would say was, and you can see a little bit more peripherally some late staining up here, but it looked to me more mechanical and didn't look like any type of a CIN. And when we took the patient out of their hard lens within a matter of a month or so, you could see the pattern had regressed, about 70% or so. The vision improved again, and with further lens adjustments, it had stabilized over time. So not everything that looks like a dysfunctional sectoral pattern is the same type of condition. So you always have to have a high degree of suspicion for other things as well. So just to give you some of the breadth. This was a patient, and I alluded to this before, that had been seeing actually multiple ophthalmologists with a quote-unquote history of recurrent erosions as the underlying diagnosis here. And you can see at the time she presented, she then developed an infectious keratitis with a ovalized looking ulcer there. But as is always the case, you have to look at these eyes critically. And you can see she's got a lot of peripheral neovascularization. It didn't look like your typical recurrent erosion patient. And you see on the fellow eye, the one that's not being treated for erosions, there's also some neovascularization and pannus. And then you pull the lid down, you look closely, and you can see obviously sort of early stage symblephora in the fornix. And this patient was subsequently diagnosed with OCP. So it's obviously important to recognize that early stage OCP may present more subtly. And I do remember a case as a fellow where we were taking care of a patient for limbal stem cell deficiency in his 90s and had sent him for some lid work. And the oculoplastic surgeon actually sent back and said, the patient has OCP. He said, what? And they said, yeah, there was a symblephron. We ended up biopsying and it was positive. So we had neglected to even notice that. It was very mild. But just remember, it's always part of the differential diagnosis. So another example, this was a patient sent in with the diagnosis of suspected limbal stem cell deficiency and edema, and referred in for a PK and potentially limbal stem cell therapy. And as you see over here, this is a different looking pattern. I'd call this a frond-like epithelial pattern with a very, very clear demarcation zone, which stains sort of late and diffusely across that area. And for those of you that recognize it, this is a CIN. So this was a biopsied and found to be a grade 3 CIN, which after treatment, patient got back 20/40 vision with topical interferon. So again, just to show that not everything that stains diffusely or has a pannus is limbal stem cell deficiency. I mentioned this patient before. Here we are now, actually 9 years since I first met her, and she is maintaining 20/40 vision despite that conjunctivalized surface because there is enough central clarity that she can actually get a 20/40 out of that right eye, and lesser but still useful 21/25 in the left. So don't throw out the opportunity to get these patients, at least try them in a scleral lens if they are motivated. Okay, so moving on to some of the more specific examples, some of the surgical treatment. Surgically, there's a whole set of stages that these patients go through depending on how they present. If they have a non-healing epithelial defect, obviously that sort of requires immediate attention, and you're typically going to go to some of your usual tried and trues. A sutured amniotic membrane or a self-retained amniotic membrane graft is usually a good place to start. Tarsorrhaphy is usually an extremely valuable tool just to stabilize these patients. And obviously, if they also have a perforation, you have to do some sort of keratoplasty or temporizing measure to handle that as well. Many of these patients, those that have cicatrizing conjunctivitis, I end up working very closely with an oculoplastic surgeon because not only do they often need multiple rounds of permanent partials, medial and lateral tarsorrhaphies along the way, there are often many issues with things like entropia and trichiasis. So sometimes rotational procedures or ablation lid procedures for the lashes are necessary. So if you do a lot of inflammatory cicatrizing disease, you're going to need to have a good oculoplastics go-to person. And then exposure is often a problem, particularly those that have cicatrization. They often have lid issues, so that's where your tarsorrhaphies and ectropion repairs can come into play. And then you get to the kind of the final stage of the corneal side of things, which is actual stem cell transplantation, which can be as, let's say, as quote simple as things like autografts if it's unilateral disease, getting to the more complicated situations which require advanced immunosuppression, such as allografts, or in some cases the hybrid autograft procedure of SLET or simple limbal epithelial transplant, easy for me to say. And then finally, you're working towards, in many of these patients, either the opportunity or the necessity to do then a graft to provide central clarity, presumably after you then address the other issues. With the other sort of option being keratoprosthesis as an alternative, although I will give a couple of caveats about that and share a couple of let's say, horror stories about situations in which those have gone awry. So a Kpro is not necessarily a perfect solution to this problem either, although they have caught on a lot because of the absence of stem cell immunosuppression necessity. So here's a case. This just kind of gives you an idea of maybe some, let's say, creative approaches to less advanced cases. Referred in with a best corrected vision of 2200, progressive over the last 2 years. Patient had a history of multiple procedures, including a trab with MMC, vitrectomy, a tube, and you can see ACIOL in the anterior segment. And when you look at this patient, you can see obviously why they're having difficulty with their vision. They have this sectoral area of, and this is a very late staining picture, so this may look sort of like an epithelial defect, which it was believed to be at one point by a referring physician. This is actually all just essentially dysfunctional, irregular epithelial cells arising from the area where presumably there was probably mitomycin C or surgical trauma that led to that area to be so dysfunctional. So in some cases, you actually, when you see the periphery, and although there is some limbal staining in other areas, it's a fairly good epithelial staining pattern everywhere else. And this is a patient that really didn't want to go through aggressive therapy, so you can, in some cases, do what's called a Duis procedure, or basically brushing the epithelium back into that quadrant. Here's a little closer up view. So what I did for this patient, essentially debrided that quadrant back all the way to the limbus. Actually, you can even couple that with a destructive procedure to that limbus area. That's the so-called Dua procedure, where you either resect or you could use any type of alcohol measure to sort of destroy those cells to try to prevent them from sending those cells down to the center. Now, I didn't do anything as aggressive as that. I debrided all the way to the limbus, coupled it with an amniotic membrane graft and temporary tarsorrhaphy. We did also put the patient on serum tears for a period of time. And this patient was able to regain 20/50 vision, which was his potential. And even now, 8 months out, you can see, although he still has evidence of peripheral dysfunction, throughout, that area there was not yet tracking back to the center. Now, I do want to tell you, this is not always going to be a long-term option, but for older patients, those that are looking for something that may not require extensive or aggressive therapy, I've had good success on more than a handful of people, even going out beyond 5 or 7 years and keeping them still functional with that. So this is a patient that had essentially what was believed to be a VZV-induced limbal stem cell failure, and also some cicatrization completely unilaterally in her left eye, which took multiple years to kind of control and get a stable ocular surface, which was for the most part very conjunctivalized. we had been back and forth. Her other eye, thankfully, was normal, but the patient was very, very unhappy with the vision. And we did ultimately put in a keratoprosthesis. At the time, it was one of my colleagues, not myself, that put it in. So the keratoprosthesis was put in. She regained 20/20 vision. However, as you may be able to glean from this picture right now, there's a little bit more going on. And if you zoom in on the keratoprosthesis, you can see that at this particular visit, there was a pretty sizable infiltrate right at the stem of the keratoprosthesis. And, you know, this is always a very gut-wrenching, heart-dropping kind of moment where you have a patient that you know is going to, at best case scenario, go through a very, very difficult process to get this better. Worst case, you know, this may be an unrecoverable problem. So even despite this being in for a year with a relatively conjunctivalized surface, you can see that area where she had still some epithelium. This is still very fragile here. Those are always going to be risk factors. So this patient did end up growing a gram-positive. It was a group D strep. We ended up treating aggressively with intravitreal, extensive topical and subconjunctival therapy. She perforated from that area, which we were able to actually temporize. Although we had talked about taking her to the OR, this was a patient that was a very poor surgical candidate with morbid obesity and other major medical issues that absolutely refused to go to the operating room. So I was left to come up with my best devices. So I did glue this keratoprosthesis. And for those of you, if you ever have the misfortune of being in this position, do know that the glue is actually a reasonably, let's say, effective binding agent to seal one of these small perforations, although extremely difficult to get off of the plastic keratoprosthesis. So you can see centrally here, there was some little areas of glue that had tracked down. And basically then down the road, you have to very painstakingly kind of debride these off with a blunt instrument, which for a difficult patient can be a little bit of a painful process. So she did regain vision, although her glaucoma progressed rapidly after this and is maintaining 20/50 vision now. This is a couple of years after that episode. So keratoprosthesis can be used, but again, patients with this, you always have to look at them with the risk factors as well. One of my top probably 5 or top 3 patients of all time in terms of memorable, but not for the good reasons. This is a patient who came into me 4 or 5 years ago, 4 weeks after a quote unquote paint thinner splash into the eyes while she was painting her house. And you can see the quote unquote tells you that this is not going to be an accurate description. So at the time she had presented, the first suspicion based on some of the limbal whitening, which you can see sort of off frame here, and this extent and sort of this appearance here is that this is a pretty severe limbal stem cell injury. So we took her for bilateral amniotic membrane grafts and temporary transorrhaphies. So nothing is easy, and this patient also had a habit, unfortunately, of making methamphetamines at home, and that was the actual cause of the injury. So a shake and bake meth bottle had blown up in her face, which one of her friends had divulged to me at a subsequent visit. And that visit was this one, when she had presented, returned back, and this is the day after she had come back. We'd taken the transorrhaphies down, anticipation for the necessary surgery, but essentially had developed a bilateral strep pneumo ulcer. Again, one of the consequences, limbal stem cell deficiency, plus in her case, she had a habit of blowing her nose and then wiping the eye with the tissue, which probably was a bad combination for these eyes. So going back to your list of surgical interventions, we knew she had limbal stem cell deficiency, but she also had now a severe, large infectious keratitis in both eyes. So we admitted her for round-the-clock antibiotics. Both eyes perforated, I think 36 hours after being admitted, and she did grow out strep pneumo, as I mentioned. And that day I did a bilateral 10mm transplants on both eyes, just to create a stable ocular surface again, and it worked remarkably well. We were able to not only to close the eye, but actually to reform the chamber in both eyes, and the infection cleared. And what you can see here, this is a week out. This is one thing that I will tell everyone, put this in the back of your mind when you operate on these patients. I saw this and I thought to myself, oh my God, her stem cells have survived. I was delighted. I was thinking, like, oh my God, we might get through this. This might not even need any limbal stem cell therapy. But the follow-up to that is when you transplant large grafts, or even those that don't get extremely large grafts, I think two things can happen. One is you may be transplanting some of the donor tissue, which may contain some residual transient amplifying cells, which can actually populate that cornea at the beginning. Or possibly you're seeing the dying gasp of whatever residual epithelial cells that they still had, because this was the best these corneas ever looked, and after that it was just nonstop worsening corneal abrasions and total limbal stem cell failure over the subsequent months. Just to take you a little bit down the fun of these kind of situations. So over the next 12 or 24 months, we were back to the OR 2 years. She was admitted, I think, 3 times along that way, and actually many other complicated issues related to substance abuse came along with that. 12 eyelid procedures, many of which were combined with amniotic membrane grafts along the way. And by 2018, we had finally obtained a stable ocular surface, albeit with tarsorrhaphies in place. And she was badly desperate to get better vision, but I would say still not the most dependable of patients. So I did consult with one of the, let's say, world authorities on limbal stem cell transplantation. This doctor evaluated and said this patient is not a good candidate. They didn't think that she would be compliant with the follow-up. So she decided then to move out of state and connected with another prominent limbal stem cell treatment physician who did give her a living-related KLAL, or a keratoליmbal allograft, back in 2018. And then a second one after that failed. And then the second one evidently got to the point that was good enough that she was a candidate for a PK and a extracapsular cataract extraction. And then, as is often the case with such patients, she just showed up at our doorstep one day. It was Christmas Eve in 2018, with a now at this point is a 6-week history of fungal keratitis. And she came home and said, "I need to be seen," and of course presented with this desmetocel. So we did an emergent PK. Within a week or so, she said, "I want to go back to where I was," and left again, and then returned to that physician. And then 18 months passed, and I hadn't heard from her. I hadn't heard from the physician. And I guess I was sort of blissfully ignorant at that point that I hadn't heard anything. So I then got a call out of the blue one day that said she was moving back to Ohio and wanted to reestablish care and was doing great. And I received that same day a letter from that physician. Told me, oh, I'd put a Kpro in. And this was a patient with an alkali burn. I immediately panicked and said, "Come in immediately," because I had a very high level of concern that this was not going to be as good as she thought it was. And lo and behold, here we are with a 180-degree inferior corneal melt now. So this just goes to show you again, limbal stem cell deficiency, although a Kpro can be used, you cannot neglect the fact that these patients still have to epithelialize and in some cases conjunctivalize that surface. And this particular case, this was compounded by the fact that she had a very severe lower lid ectropion with a poor upper lid blink function, which was part of the reason why I think the other doctor had pulled up a conj flap, hoping that that would solve it. But quite obviously here, she was not doing great at this point. So we did end up taking her for an immediate tarsorrhaphy, and we are now 4 months after she had come back with almost 100% closure of this defect, which goes all the way down here like a horseshoe shape with basically just conjunctivalization to the margin, but the eye is hanging on. So a little happier case here. So this is a patient, 32-year-old that had a unilateral chemical burn, and then subsequent treatment here with an autograft. So the autograft in which you can harvest either a more traditional sort of 6 clock hour or 2 3 clock hour segment of conjunctival limbal epithelial cells, and then transplant here using a depth of about 300 microns. And then the alternative being the so-called simple limbal epithelial transplant, or the SLET procedure, which I think has a variety of different proponents for it, but not everyone I think is sold on its long-term utility. So this is that patient after the procedure was done. And then you can see here, this is the harvest site. You can see healing well. And then here is the grafting site. And you can see now that improved up here, that nice glistening epithelial reflex up there, indicating that the epithelial cells are now working properly. And then that patient, after getting a stage PK 6 months down the road, was able to regain 20/25 vision. And he pretty much has held on to that pretty well over the last 3 years. So a good case for using the other eye. And I would always caution, you know, you have to be extremely confident about the health of the other eye. I would not recommend this if they are a contact lens wearer. I'd not recommend this if they have any possible concern that they had a chemical burn to the other eye as well. Just do not want to sacrifice the better eye. This is an example of, again, some of the worst stages you can get into. This was a patient also with many medical comorbidities, which made her a poor surgical candidate, that had some of the most recalcitrant HSV I've ever seen in my life, despite maximum medical therapy. You know, essentially nearing perforation. We had to just stabilize it with a Gunderson flap, which was done with local anesthesia, and she did end up expiring within like 6 months due to her other conditions. So this was at least prevent her from having to have the eye removed, which was her goal. This is another one of these patients where I've gotten to know him extremely well over the last 3 years. This was instead of Christmas Eve, this was a 4th of July patient. So he and his brother were playing at the time, his younger brother. He dared him, he wouldn't possibly shoot a Roman candle directly at him, and his younger brother, up to the task, did. It hit him directly in the eye, and obviously a direct impact as well as a large thermal burn. So this here is the same eye, and I don't have an early photo, but this is the same eye now after his 3rd keratoid limbal allograft. This patient I did partner with Ed Holland with because of his young age and high risk. And even despite all of our best efforts, we are now years out, and we're still having a hard time getting this to take due to issues with exposure as well as rejection. So these can be extremely difficult even under the best hands. I wish I could say that was his eye, but this is a different case here. And I only show you this one because this was a recent patient sent in for a history of suspected limbal stem cell deficiency because of the superior staining pattern. And although that image is a little out of focus, never forget to evert the upper lids. This was the most calcific concretions I've ever seen on a lid. And after debriding all those, her eye went back to normal and she was delighted. And I'll close here just with a couple of cases just to plant one other seed in your mind, which is the role of genetic diseases in limbal stem cell deficiency. This was a patient that had come to me, I think 7 or 8 years ago, and referred in for these kind of bad nodular changes and peripheral neovascularization, and obviously some evidence of perhaps either limbal stem cell dysfunction, if not limbal stem cell sort of staining 360. So this patient otherwise had been doing fairly well or managing up until the last 5 years, at which point her vision started to decrease. And she was not a contact lens wearer, and the other eye essentially had a very similar appearance. So what's interesting is her daughter then presented separately with no referral. She had come in on her own for an evaluation for what was described as, again, a cornea problem. And you can see on her eye this pattern, which is peripheral limbal staining. And this is not a true defect, but basically pooling up here. But 360 with this sort of abnormal, let's say kind of early fibrotic changes around there. So you look at that, and these patients are 25 years apart, but you could almost imagine that these are just 2 images frozen in time from the same patient. So that led me to believe, I said, aha, well, we definitely have something going on here. I started to think of the possible causes and took some more history. So with further investigation and questioning, I said, do you have any other history of eye problems? I said, oh, I have a sister with, this is the older patient, I have a sister that has aniridia. And then we later discovered that she had been in fact diagnosed and had a PAX6 mutation. So this is so-called, what used to be called autosomal dominant keratitis, which was later then converted to the name of PAX6 keratitis, which is sort of a form of a very specific appearance of limbal stem cell deficiency, characterized by this circumferential staining, typically a very slow progression over time, and they tend to get these sort of multifocal nodular changes as well. But what's interesting is neither of these patients have any semblance whatsoever of the iris changes, which was also described in this paper by Kathy Colby, who was the lead author when they published on this finding. So not only that, these actually can be treated. So they don't have total limbal stem cell deficiency in many cases. So I did end up doing essentially sort of a nodular keratectomy to help with the epithelialization, amniotic membrane, and tarsorrhaphy, and the patient was able to improve back to 20/40, which was near her baseline, and she was able to regain her driving. And then lastly, so then there's a third generation. The daughter or the granddaughter of the initial patient of the proban there also came in with an even milder form of this, just to show you that these changes are present even at a very young age. So if you ever see sort of a circumferential kind of unusual staining pattern in a young patient without any other obvious risk factors, think about genetic factors, especially PAX6. So I hope that meandering or sort of disorganized tour of limbal stem cell deficiency and its various manifestations and treatment was useful to you. Thank you all for your attention. I'm assuming your attention because I can't see you, and I'll be happy to open the floor to any questions.
Yes, Dr. Goshe, we did have a raised hand from Dr. Jaber. Dr. Jaber, I am going to open you up to allow you.
I do not acknowledge my former fellow, Dr. Ryan Jaber.
Okay, Dr. Jaber, you can ask your question if you'd like to.
Be kind,
hi, Dr. Goshe, how are you?
Ryan, how are you? Good.
Good, good. I actually hit the raised hand button on accident, and I tried to unraise it. So I don't have a question except just to say that was a great talk, and I appreciate your knowledge on the subject.
Hey, well, it's great to hear from you, Ryan, and I'm glad you raised your hand anyway. So
yeah,
don't be a stranger. When COVID is gone, you'll have to come back to town sometime.
Sounds good.
Okay, and we do have a couple of questions in the Q&A panel. First one is with LSCD having both a genetic component and correlated with dry eye. Do you see an actual increase of LSCD in people of, for example, Middle Eastern descent? And is there any difference in treatment with less hospitable environments like desert regions?
That's a good question, and I'm going to openly admit I don't know if there is a strong ethnic correlation to it. The one that is most relevant to my exposure in our practice is that it tends to be more females than males. But ethnically speaking, I don't think I've seen. I'll put it this way: there's probably an association I could not tell you. I would say that certainly when we see patients that come from Middle Eastern countries, especially those that are older and have other issues, trachoma being ubiquitous in some of the countries that didn't have access to early intervention, 50 or 60 years ago. Now, does dryness impact it? I mean, I'd say without a doubt, any kind of an arid climate is going to make any type of ocular surface problem worse. Does it actually make the limbal stem cell deficiency progress more rapidly? I would say I couldn't speak to that with any confidence. I would say, though, that my inclination would be that it couldn't possibly help. And if anything, it would probably make the situation, if not worse, at least just a little bit more difficult to manage.
Okay.
Sorry, I can't give you any better than that.
And we do have another question from Dr. Jonathan Lass. He said, Jeff, great presentation. Do you have any experience utilizing anterior segment OCT to diagnose and manage LSCD? So
thank you, John. It's always great when you have people that are way more experienced than you asking you questions. So we have used it actually, and I would say I don't think it is an exceptionally useful diagnostic tool for us. We have used it in some cases, I'd say more to differentiate CINs from other causes of pannus. Oftentimes you can see the epithelial pattern and the transition zone is more apparent in those cases. I don't have any personal experience really using it with any great success for limbal stem cell deficiency. I think it's more clinical slit-lamp diagnosis in most cases. I know historically cytology, impression cytology was utilized, but I think that for most patients we've gone away from that because oftentimes you can make the judgment by the appearance. It doesn't usually change my management. This is fun. Thank you for giving me the opportunity to speak, and I wish I've I wish I'd been able to attend more of the other presentations. You've done a great job putting up a great slate. Speaking both to Mary and Diane, and thank you again for giving me the opportunity.
Oh, thank you. Yeah, it doesn't look like there's any other questions coming in. So once again, I would like to thank everyone for joining us today. The webinar has been recorded and will be available on the website to view on demand. And again, a very special thank you to Dr. Goshe for serving as today's speaker and for providing us with your invaluable expertise on this subject. So have a wonderful evening, everyone. Thanks again, Dr. Goshe.
And thank you, Dr. Wiley. I'm glad you tuned in. You just sent me a text on my phone.
All right. Good night, everyone.
Thank you so much.